Okay. So we'll give folks a minute to get connected and get
Okay,
organized.
sounds good.
Okay, I think that's everyone. I don't see the number jumping too much anymore, so we'll go ahead and get started.
Awesome.
So, hi everyone. Thanks for joining us today. This is
Everybody.
the Q&A webinar with Shiv from a local pharmacy in Cochrane. My name is Emma. I'm a client service coordinator with the Parkinson Association of Alberta, and I'll be moderating this webinar. If you have any questions to submit during the webinar, please submit them in the chat box. There's a little chat blurb icon on your screen, and you're welcome to type your question in there to the panelists, and then we will get them. We'll look at them and get them answered. And I will get the chat started so you guys can see where it is and then submit your questions. Just as a disclaimer, this webinar will be recorded. All of the information provided in the videos by the Parkinson Association and featured speaker are furnished strictly for educational and entertainment purposes only. The service is not intended to be diagnostic, prescriptive, or replace the relationship, advice, and/or care of your physician. General questions about symptoms, treatments, available medications, complementary and alternative healthcare therapies, and current research will be fielded. So today we're joined by Shiv, and Shiv, like I mentioned, is a pharmacist in Cochrane at 2 Pharmacy. He's worked with us before and done a couple presentations with us before, and he's going to speak today about Parkinson's medications.
Hi, everybody. Hey, it's great to be here. Thanks for having me today. As Emma said, I've done a little bit of work with the Parkinson's Society before, just locally in Cochrane, where I work. Been able to provide a couple of presentations. So I'm very privileged to be here. I hope I can, help you guys the best I can today and answer your questions. So just to start, I'll discuss a little bit about myself. So I'm hoping you guys can all see my screen here. So a little bit about me is I graduated from the University of Alberta in 2010. So it's been a while. I've been practicing for about 11 years. I practiced across Alberta, including managing a location in Airdrie. I worked in Beaumont, Alberta, worked in Sherwood Park. So various locations. I've been very privileged to be able to see a lot of different patient care throughout my career. No, I'm one of the pharmacists who has obtained additional prescribing authorization as well. So I do and have an enhanced practice where I do some prescribing, not particularly for Parkinson's. My focus is more in travel medicine and vaccinations. I do run and operate a travel clinic. It's called 2 Travel Clinic. I obtained my certificate in travel health in 2015. I also, at my store, primarily do most of the clinical focus work, and I'm known more as the clinical pharmacist. That includes services like injections, medication reviews, answering patient questions, doing smoking cessation counseling, and various. So again, enough about myself, but we'll kind of carry on into the presentation. I was privileged enough to get Emma to forward a few questions ahead of time, which I'm going to focus on preliminarily because I was able to do a little bit of research about each question. So I'll start with the focus on there, and then I'll pass it over to Emma, and she'll field any more questions thereafter. I'll also do a small and brief presentation on medications, which we can, if you guys have more questions about, we can elaborate on further. So we'll start from there. Now, the first question that was supplied to me was this. It was, how common is the prescription of Peridone for nausea associated with Parkinson's disease? So it's a very good question. It's actually, so from my research, I found that it's actually the most common medication prescribed for nausea and vomiting in Parkinson's disease. So when levodopa or a dopamine agonist are initiated, usually domperidone in doses of 10 to 20 milligrams, 30 minutes prior to each dose. They can actually be helpful in minimizing gastric upset and also orthostatic hypotension, which is that feeling of lightheadedness you get when you wake up from a seated position or things like that, that lightheaded feeling, which is attributed to a drop in blood pressure. One thing to kind of keep note of with domperidone is it's not suitable for everybody. So we do caution its use in cardiac patients as it can be associated with things like ventricular arrhythmias. So especially patients with AFib or uncontrolled AFib, that would be a concern. So that's something you always want to talk to your doctor about before they initiate a therapy with domperidone. But it is the most common agent used for nausea associated with Parkinson's disease. Now, question number 2. Again, this alludes more to that domperidone question, was about the side effects of domperidone. So it said the side effects of domperidone are quite extensive. Is there any other medication that is similar to it? So again, like through my research, I kind of found that domperidone still remains the preferred treatment for nausea and vomiting in Parkinson's disease. There is another medication in the same class called metoclopramide. However, that medication is associated with even more side effects and is often not used because it can cross the blood-brain barrier and cause more concerns in Parkinson's disease patients. Now, this is just a quote I found. Domperidone, a dopamine antagonist that does not easily cross the blood-brain barrier, is considered to be the gold standard for treating GI symptoms in patients with Parkinson's disease, because the risk of developing extrapyramidal adverse effects is considered to be minimal from it. Now, the most common side effects I found with domperidone were dry mouth, so about 1.9% of patients experience that, and headache and migraine frequently as well, that about 1.2%. Now, I also found that when I was reading up on use in Parkinson's, it suggested not to use more than 30 milligrams per day. Now, that being said, doses are still individualized and tailored by your prescriber. And I have seen higher doses, again, in certain circumstances. So, don't be surprised if you are on a bit of a higher dose. If that's a discussion you want to have, make sure you certainly have that with your prescribing physician or neurologist. So the next question that I had was, is there a max amount of levodopa per day? So this was a bit of a tricky question because levodopa dosing should actually be individualized by your neurologist. I really could not find a stat that said, there's a maximum dosage, because every patient's going to have a different need of the amount of levodopa. It's most often combined with carbidopa, hence Sinemet, which is the levodopa carbidopa combination, because it leads to a better effect and allows people to use less levodopa because the carbidopa maximizes the amount of levodopa that's available. Now, what I found for dosing for the carbidopa component is there is minimal experience in using more than 200 milligrams of that carbidopa per day. Now, again, have I seen higher doses like that in Parkinson's patients? I certainly have. So those doses, again, should be individualized and tailored by your neurologist or your prescriber, because every patient is going to have their own individual need or amount. So again, dosing regimens, again, make sure they're tailored to you, and your dosing regimen may be different from other patients for sure. Now, next, question 4 was, how much levodopa is too much? So I think we kind of alluded to that in the question we just answered. It's going to vary between patients. Some patients are going to require a larger amount than others. It should definitely be individualized. Now, everyone's dosing regimen is going to be different. I do have examples of typical dosing that I kind of pulled out for you guys to get an idea. Again, it may not look like your regimen, but these are typical usual doses. So usually for the IR formulation, we can see anywhere between 100 to over 25 combination to 150 over 37.5, 3 to 4 times a day. Excuse my medical language that I wrote in there. The TID means 3 times a day and the QID means 4 times a day. So that's the usual regimen is what we see. Now, for the controlled release version, the usual regimen we see is usually about 200/50, 4 times a day is what I found. So the next question was more about symptoms and side effects from the medication. So what should someone who is experiencing additional symptoms like dyskinesia or hallucinations from levodopa, like too much levodopa, do? So this is a very tricky question for me to answer because the answer to it is going to be individualized to your needs and to your experience. I was able to find this handy chart that we use in our pharmacy in terms of how to manage complications with levodopa. So if you look at the chart, basically where it starts out is, if you're having any associated motor complications, we look at, is the problem more due to end of dose wearing off from the medication, or is the problem more with the dyskinesia? So if we focus on, what's my left of the screen here, where it's the end of dose or wearing off, if there really is no mild or no dyskinesia, really what we can do is we have a number of options like increasing the frequency of levodopa, adding entacapone, adding a dopamine agonist, or adding rasagiline or sulfonamide, or changing it to slow release levodopa. Now, if there is a moderate dyskinesia as well as the end of dose wearing off, some of the options include things like adding amantidine, increasing frequency but smaller doses of levodopa, or decreasing levodopa and adding a dopamine agonist. So that would be with the moderate dyskinesia. Now, if the problem is more of the is the dyskinesia with mild or no wearing off, lastly, we can add amantadine, we can decrease the levodopa. If the patient is on an anticholinergic medication, which I will allude to a little later, we would discontinue that. Or we would discontinue like a MAO-B inhibitor if you were on that. And again, we'll get into those specific medications as I will go over those. And then if there's any unacceptable side effects or lack of efficacy, there is surgical procedures available in Canada. Again, that should be discussed with your neurologist. And there's also an intrajejunal, so kind of into the intestine, levodopa, carbidopa infusion that's available in Canada as well, which, if all else fails, then we do start patients on that. So now, the next question was a very tricky question. I couldn't find a lot of information on this one, but is levodopa addictive? So my answer to this question is, honestly, possibly it could be. When you look at dopamine itself works on the reward centers in the brain. Now, from what I found in the few studies I read and some of the articles I read, it would honestly be more of a concern in patients that that were non-Parkinson's patients that decided to take this. I have not seen it be an issue with a Parkinson's patient. But again, like that choice to start levodopa should always be discussed with your neurologist, your primary care provider. They'd be able to assess pros and cons and answer, that question about addiction in more detail. In my clinical experience, I haven't really seen it be a drug of abuse or addictive at all. But again, I'm not an expert in that area. That is something you should definitely field to a neurologist for sure. No, the next question was about a new medication called Kimobi. So it's a dopamine agonist. It's a sublingual film. And I had actually written about this many years ago during my presentation in Cochrane, that it was still in the preliminary stages. It got approved in the States, and it actually has been approved by Health Canada now. Now, looking at our current Parkinson's patients that we have in our practice, none of our patients are currently using Kimobi. I did run a search through our wholesaler to inquire, if it's available. And right now, through our wholesaler, there was no availability. Also, I ran a search through Alberta Blue Cross for coverage purposes, and I noticed that there really is no coverage under Alberta Blue Cross yet either. So, it leaves kind of a question mark. So I don't know, maybe there's no widespread usage of it or prescribing yet, or coverage issues may be of a primary concern. I particularly have not seen Kimobi be used yet. All right. Next question is, what is the status on the restock of Sinemet in Canada? So this was actually a very good question, because I know previously when I've done presentations for Parkinson's patients, they have expressed the difference between brand name and generic formulations in effect and efficacy for their conditions. And I know a few years back, there was a lot of shortages occurring, a lot of concern occurring. Now, what I found is the CR formulations, or the controlled release formulations, appear to have been discontinued. So when I went on our wholesaler to see if they're going to be restocked, it literally said discontinued for those. Now, what I did found for the IR formulations, with the immediate release ones, they're showing a possible restock for mid-March. Now, it's hard to say if that's going to be conclusive, because we often don't quote and tell people that shortages are going to end at a certain point, because we are currently living through a pandemic. Drug shortage supplies have been a significant issue. Manufacturing has been an issue. So what I've seen is mid-March. So what I'd encourage you to do is, if that's a big concern for you and you need, you want that brand name Sinemet, do speak with your local pharmacy sometime maybe the first week or second week of March to see if there is some restock for that immediate release formulation. All right, question 8. So what is the difference between Sinemet and generic forms, which is, again, a great question to kind of lead into from our last question. So a generic drug is essentially, it's a copy of a brand name drug. The generic drug it's considered pharmaceutically equivalent to the brand name, contains identical medicine, the medicinal ingredient, in the same amounts and in a similar dosage form. However, it may have different non-medicinal ingredients than the brand name drug. But the company that's manufacturing the generic always has to show that this does not affect the safety, the efficacy, or the quality of the drug compared to the brand name drug. Now, there may be many generic versions of the same brand name drug, and they are usually available at a lower cost. And for cost saving effect, often insurances like Alberta Blue Cross, our most common insurance in Alberta, will adopt a policy to cover only up to the generic cost of a medication once it becomes approved, because in Canada, it's considered to be really equivalent, at least in its pharmacokinetics and the way that it acts in the body. So that really is the difference between the two. Now, lastly, I had a question that was a little bit more patient specific about a patient who had been using about entacapone for about, levodopa carbidopa for about 5 years, and entacapone for about 1.5 years. It stated they get dyskinesias, which manifests as a twisting back and forth on the right foot. Also gets dystonias, which manifests as a twisting in the torso with the right shoulder pulling back and the right pinky finger extending up. Really, what should I do? So, I totally feel for you. It sounds like, this is a tough situation to be going through. No, really, I don't really have an answer, because it's hard to get into patient specifics, especially during these webinars, as we don't have all your health history. We don't know your background health, your Parkinson's progression, things like that. So, I would really encourage you to talk to a neurologist about a possible medication adjustment or an addition or a change. Dyskinesias can sometimes be managed, as previously referred to in our chart, by adding things like Amantidine or increasing frequency but smaller doses of levodopa, or again, decreasing levodopa and adding in a dopamine agonist. I don't know if that would be right for this particular patient who posed this question, but it'd be a great question to pose to your primary care provider. Is there a change that we can possibly adjust to help limit these effects that we're getting, right? Dystonias themselves are often a complication of Parkinson's. It may be due to the dystonia itself may be due to a wearing off effect of the medication. So optimizing or changing medication regimens may be able to help in reducing that for sure. So again, really best to talk to your primary care provider to get an idea of what would be best for your case for sure. But a very good question. So again, I refer to this chart a lot. This chart is great because it really kind of explains, some of the motor complications that can be induced by levodopa, how to manage them. So this is really what I think it's a great chart to have for reference in terms of what options there are. Now I'm going to take kind of a moment to roughly just go through medications. As Emma had talked to me about, going through the basics of medications would be, something that people would be very interested in. So I'm going to kind of go through the presentation that I went through more quickly. This is the one that I did for the Cochrane group. So, I mean, I really don't need to go through too much of this. This is more just background information about Parkinson's. It was first identified by James Parkinson in 1817. Mean age of diagnosis is about 60. Men are about 1.5 times more likely than women to have Parkinson's. It's got four main initial symptoms, which many of you may have experienced. So things like shaking, stiffness, slow movement, asymmetric onset on one side of the body. These are all the result of damage to the nerve cells in the brain that slowly worsens over time. Now, this chart just explains how common these symptoms are. I mean, the ranges are huge. I mean, it really can allude to a lot of patients can have all of these. Some patients can have some, but it's going to be an individual patient experience for everybody. But those are kind of the figures there. Now, some of the symptoms that may occur kind of later in the illness include things like loss of eye blink, loss of muscle tone, increased amount of saliva, constipation, dizziness upon standing, dementia. These are all later effects, which could be attributed to the illness as well. Now, what causes it? Unfortunately, we don't know. We don't have any conclusive answers, but really the most current theory is, age-related decline in nerve cells, environmental toxins, genetic factors. All of those can come into play and impact the causes of Parkinson's. Now, what we know is symptoms occur due to loss of nerve cell function in the brain. That affects molecules that transmit the signals in the brain. So really, these are the two molecules that transmit these signals, so the dopamine and the acetylcholine. Over time, what happens is there's less dopamine release, which causes a relative increase in the acetylcholine levels. Now, how do we manage this? So in terms of drugs, how we manage it is, one is increasing the dopamine. Number two is decreasing that acetylcholine. Now, non-drug therapy includes exercise, activity, rest, occupational therapy, physical therapy. But from a medication perspective, it really is focusing on those two neurotransmitters. These are obviously our goals of therapy, which I won't go into too much. Now, medications, I will chat about these because, again, this is, I believe, where the most interest comes and where my area of expertise is. So there's 6 major classes of drugs here. So the number one is the levodopa carbidopa, which many of you know as the Sinemet. Then there's the dopamine agonists. We've got the MAO-B inhibitors, the COMT inhibitors. We've got anticholinergics and amantidine. And I'll roughly go through each of these classes so you guys have an understanding of how it works. Now, how your medication is chosen, it's going to differ per patient. It's always chosen based on what's right for you. So when you have those initial conversations with your primary care provider and your neurologist, they're going to factor in specific factors to you to see what they would start with and how they would adjust their therapy. So really no easy answer in terms of, we start everybody on a certain regimen. That's absolutely not the case. It's going to differ for everybody. Now, this is kind of how these meds work. Now, the levodopa itself, it acts directly as dopamine. So helps with the balance by increasing those dopamine levels, getting everything back in balance. Now, Sinemet itself is combined with the carbidopa, which is the best combination to limit side effects and enhance effects. So in the brain, if we look at the top corner, the levodopa gets converted to dopamine, which is what we need to get that balance. But in the body, the levodopa, because of the carbidopa, doesn't get broken into the dopamine. hence enhancing the amount of dopamine that can go into the brain to help with the condition itself. Hence the reason for the two together. Dopamine agonists themselves act directly as dopamine. So those are medications like Mirapex, Requip, Doxanex. They act as dopamine to help get that balance back together. Now, this is an idea of how dopamine gets recycled in the body. So we have two different enzymes that tend to break down the dopamine, and we need that dopamine for effect in Parkinson's. So now these two enzymes are called the MALB and the COMT. So now if we look at the class of medications known as, the COMT inhibitors or the MALB inhibitors, we've got these options like the Azilect, the Aldopril, and the entacapone. So those directly act on those enzymes, preventing the breakdown of dopamine, enabling us to use that dopamine for the condition itself. So that's how those work. Now, the other way of tackling it, as we mentioned before, would be to reduce the amount of acetylcholine, because we know that in Parkinson's, we have more of that. So we need to reduce that. So these anticholinergics work directly in that. They help limit or reduce that. So these are some of our older medication, things like benztropine, procyclidine, trihexyphenidyl. I'll be honest with you, we don't see a lot of these. They are attributed with a lot more side effects than some of the newer Parkinson's medications and the levodopa, carbidopa, but we still do have some patients that use these for certain effects like tremors, etc. And again, that's the balance that it works on. So, reducing that amount of acetylcholine. And then lastly, we have amantidine, which, to be quite honest with you, we don't know exactly how amantidine works. It's an antiviral, but we've been able to find that it has some effect and benefit in Parkinson's patients. Particularly, it can help with levodopa-induced dyskinesias, is what I've seen it being used for. There is some effect on the presynaptic terminals of the nerves, where it can increase the amount of dopamine from there. But the full effect is not widely known, but we do know that there is some benefit from amantadine as well. Those are the major 6 classes of meds. Next we have, how to manage these medications, because, as a Parkinson's patient, I can only imagine how difficult it can be, sometimes keeping track with dosing regimens and, keeping track with medications in general, especially if you get started on a few of these classes of medications at a time or over time. That's why we're here. As pharmacists, our job is to help you understand, what, when, and why in terms of your meds. If you book a local medication review with your pharmacist, which is what I often do in our store for our patients, including our Parkinson's patients, is I help them make a best possible medication list, help them chart out their meds, help them understand what each of them is for, when to use them, and why. We can also help you get set up with things like a patient diary chart to keep track of symptoms and side effects. So we can notify your prescribing physician or healthcare provider if side effects are getting unmanageable. And we can also help with things like organizational devices. So I think for Parkinson's patients in general, blister packs or compliance packaging is very, very important. And that's something we're more than happy to help with. And again, that's a lot of what I do at my practice, is sitting down with patients and helping organize their meds and putting them into compliance packaging. We also sell things like timing devices. What's great is most of us have smartphones these days. There's great apps you can get to help you remember when to take meds and get alerts. And then we also sell basic things like pill dispensers if you want to manage your own medications as well. Really, that kind of takes it in terms of my presentation. So I apologize. I've been talking a lot here. I went through a lot of information there all at once. But I want to leave it at that. Really, next, I'm more than happy to field some questions, which if you kindly send them to Emma, she can convey them to me. In terms of, if you guys have any specific questions, I can always do my best to try to help you answer those questions. I will be honest with you. Every patient is different. I may not be able to answer your patient-specific questions today. So if you guys have more general questions about what we've talked about, that would be great. But again, field them please to Emma, and she'll pass them on to me here. And if there is something that I can't answer, I'm more than happy to provide my email address to Emma, and she can pass me these questions, and I can always try to send you a response via email as well.
Thanks, Shiv. I've got a couple questions here, and there's some in the chat, so maybe we'll start with that.
Sure.
So we talked a little bit, or you talked a little bit about nausea, but someone is wondering what they can do if they're feeling nausea from the levodopa.
Yeah, so that's a very good question. So I think we alluded to this a little earlier. The gold standard in nausea and vomiting management in Parkinson's still is domperidone. I understand that for some patients that may not be the only option, but because of its dopamine antagonist effect in the body and its ability to help with the nausea, vomiting without causing complications, it is often where we start. So I mean, that's where I would start for patients with Parkinson's disease. However, it may not work for everybody, right? So it's an individualized kind of case scenario if that medication is not right for you.
Is there anything more natural that folks can take when they're starting the medication and just getting their body adjusted to the medication?
Yeah, so I mean, that's a good question. No, like in terms of natural health products, I'll be quite honest with you. I don't ever encourage people to take natural health products when initiating their Parkinson's medications, because a lot of the natural health products are not studied in terms of clinical interactions. There's no widespread trials, but there's always non-drug things you can do to help manage nausea. So, I mean, initially, when people are starting their levodopa carbidopa combinations, we often might even tell people to take them with food initially, even though that's not best practice, but that helps initially to manage some of the initial onset nausea, vomiting, which may go away. For most people, it will over a couple of weeks. No, the best practice in terms of taking your levodopa carbidopa is usually on an empty stomach, right? But initially, to help manage things like nausea, we may suggest taking it with some food or a small snack to help with the management. So there's always non-drug things you can do, but I would be cautious about using natural health products. I mean, there are some that are appropriate and they would work and they'd help, but for each individual case, I would certainly, talk to your pharmacist before starting anything, because, we can always plug it into our interaction checker. We can warn you about potential complications and, steer you in the right direction for sure.
Good. Okay, thanks. The next question here is related to entacapone. So it's saying that someone recently started entacapone and they're not feeling an increase in the effectiveness of their levodopa. So they're wondering, roughly how long does it take to feel the effectiveness once you've started a new medication? And is there any more information that you have on entacapone? I know you did cover it a little bit.
Yeah. So a great question. So entacapone works a little bit differently than the levodopa carbidopa, but it can work hand in hand because it directly affects that COMT enzyme, and it inhibits it so that dopamine is not broken down, hence enhancing our ability to get more dopamine from our medications, or naturally as well. In terms of effect, usually when you start taking entacapone, you would start noticing that increased dopamine production almost immediately, just similarly to when you would be starting like a Cinemet, like a levodopa carbidopa combination. However, it may vary per patient. I always tell patients that we can't dismiss a medication within the first few days of trying it, because we don't know how your condition has progressed. We don't know if we're going to get a full effect. For a Parkinson's drug, I always tell people to give fair trials of between 3 to 4 weeks for medications to assess benefit. But I mean, obviously, if side effects are a concern, they should be talking to their primary care provider sooner, especially if it's affecting their quality of life or functionality. But for each patient, unfortunately, it's going to be a little bit different. But I don't think we can conclusively, say a medication doesn't work within a few days or a few weeks. I think we do need to give them a fair trial, usually about 3 to 4 weeks for Parkinson's meds before we reassess them, unless, of course, a patient is experiencing a number of side effects, right? So that would be my best answer. Again, I'm not considerably an expert in the initiating of entacapone. So if there is concerns about the therapy, please do reach out to your primary care provider, your pharmacist, your individual pharmacist, and they can always help you reach out to your primary care provider to make necessary changes if necessary.
The next one here is there a best way to take levodopa in terms of taking smaller doses more often or larger doses less often? I understand it's probably individualized as well, but
Yeah, no, great question. Great question. And again, like when I did the presentation with the Cochrane group, these are very similar questions to then. And honestly, there's no individual answer to that. For some patients, the controlled release formulations may be the best option, especially if there's a wearing off effect of the immediate release preparations that are available. Also, depending on disease progression, if you're late into the illness or early into the illness, then it may alter the way that some of these drugs work or behave. So it's going to be very individualized. Now, in terms of best practice for taking the levodopa carbidopa, we usually do recommend, especially with the IR formulations, empty stomach is best, but it's not often great when you're starting that and there's a lot of nausea, vomiting. So initially, we may even tell patients to take it with a bit of food or a snack to help limit that, ensure adequate hydration and things like that. But it is best taken kind of on an empty stomach if possible, which is not always possible for Parkinson's patients, especially if they're taking their medication 6, 7, 8 times a day, right? So best practice is consistency and working within the parameters that you've been prescribed and going accordingly. And often over time, by keeping patient diaries or charts or tracking symptoms, that's when we can kind of find out or figure out, what's best for you, right?
okay. The next set of questions are all kind of related to sleep. So someone's asking, is there a correlation between the Parkinson's medications and sleep? They noticed when they were first diagnosed, they had really vivid, violent dreams, but since taking the medication, those dreams have subsided. So is there a correlation between them?
Yeah, that's a very good question. So no, we know that these medications are going to affect neurotransmitters in the brain, and they do cross the blood-brain barrier. Hence, that's how they work. So there's no doubt that initially some of these medications are going to have an impact on things like sleep, mental health, etc., just because of the way that these medications are acting. So we do find that sleep can be distorted by certain medications, and some Parkinson's patients have reported vivid dreams, hallucinations. That's what we call CNS or brain effects from the drug. Now, sometimes these improve with time, sometimes they don't, and that's when we need to alter or change therapy accordingly. Also, like REM sleep disorders are often even discovered in Parkinson's patients before they even get diagnosed with Parkinson's itself. So some patients have reported, prior to even diagnosis, 10, 15 years before, where they have vivid dreams, acting out in their dreams. It's very interesting because it has been reported prior to diagnoses. There is ways to manage it. I was able to find a few options for REM sleep disorders, just in some of the clinical books that I had. I know that melatonin is sometimes used to help with these REM sleep disorders. Now, the dosing regimen I was able to kind of find for that would be anywhere between 3 and 12 milligrams of melatonin tailored to individual effect. And then I also found that for some REM sleep disorders, clonazepam is an option for some patients. Not the best option because it can lead to certain side effects like drowsiness. It can affect gait, which we don't want, right? It's got a long half-life, but we do know that for certain people that have mainly the sleep issues, dosing of 0.25 to 1 milligram of clonazepam may help as well. But that has to be tailored to each patient as well. So, a very good question. So again, like if that's something that's affecting you in terms of sleep disorders, please talk to your primary care provider because maybe there are options like that to help you manage. And it's usually not an instant effect where we can change these. Sometimes it requires changing certain medication regimens and adding things like what I just mentioned. So.
Okay. And then the other one is, are there any medications that help with restless leg syndrome from Parkinson's?
Yeah, so that's a very good question too. So, restless leg syndromes they're quite common. Certain conditions would find that you would have more restless leg syndromes. Like for instance, my wife was pregnant, about a year and a half ago, and she experienced lots of restless leg syndrome. So certain conditions like pregnancy or even Parkinson's can increase your chances of getting restless leg syndrome. We have used various medications to manage restless leg syndrome. Dopamine agonists are actually quite often used. So medications like pramipexole or ropinirole, I've seen used. I've also seen certain agents like gabapentin, which is actually an anti-epileptic, but we rarely ever use it for seizures, but we've seen it used for management of restless leg syndromes as well. So there are options, again, patient specific. I wouldn't say that those are the best options for everybody, but talking to your primary care provider, you may be able to find a certain option and certain dosing regimen which helps with that.
Okay. And then kind of related to that, are there any medications that interfere with levodopa?
Medications that interfere with levodopa. So really, I don't know of a lot of medications per se that would impact levodopa. But I think that really like food, protein, things like that can impact levodopa carbidopa absorption. Certain things like laxatives can increase the peristalsis of the stomach. So, timing certain meds at the same time as taking a laxative may impact the absorption of it. But in particular, I don't find any significant, drug interactions that I can mention here right now. I mean, certain natural health products for sure. Again, very specific, but if there's a particular medication you have in mind, what I encourage you to do is talk to your pharmacist, because we have some advanced software in our pharmacies which allow us to check drug interactions quickly and readily to ensure that what you're about to take it does not interact with each other. And often as part of the filling process, when we are doing pharmacy and dispensary work, we always check for drug interaction. So if you're started on a new therapy or new medication, we would always assess a clinical interaction and discuss it with you prior to releasing the medication. So always have that conversation with your pharmacist. And, if your pharmacist seems like or thinks that the interaction is significant, they will always contact your primary care provider. But off the top of my head, I can't really tell you because we have so many drugs out there. That's why we always run these interaction checks when we're filling, and we do it specifically for patients. We even have natural health product software in the pharmacy too. Again, it's a little bit more limited because there's not as many clinical trials or studies in terms of interactions with Parkinson's meds, but there's always things that we can help you look up. So always ask your pharmacist that information.
Okay. And do you know of any relation between antihistamines and levodopa?
And that's a really good question too. So certain antihistamines, antihistamines could be categorized like Benadryl, like Gravol is considered an antihistamine. They actually have an anticholinergic effect. So if we look at kind of the chart we looked at a little while ago, where we're looking at that fine balance between the dopamine and the acetylcholine, certain drugs, they'll lower the amount of acetylcholine to increase the amount of dopamine. So when we look at over-the-counter drugs, if you are using things like anticholinergics and antihistamines at the same time, which have an anticholinergic effect, there can be drug interactions between those. Now, in terms of how it's going to affect levodopa carbidopa, it's going to actually enhance the amount of dopamine. Now, that's not always good for every single patient. So that's why you always have to watch for drug interactions before starting anything new. So when you do, are about to go get a new over-the-counter med, talk to your pharmacist, because they will be able to, put it in our interaction checkers and make sure that that's appropriate for you. There are certain antihistamines which have less of that effect. So more of like our second generation antihistamines like Reactin, Claritin, Arius, they're not going to have as much of an anticholinergic effect as, say, things like Benadryl and Gravol will. So, that's why it's always good to talk to a pharmacist to see what would be more appropriate with your medication therapy, because we could check those interactions for you right then and there.
Okay. Someone is asking, do you have any knowledge of weight loss as a side effect of Sinemet?
That's a really good question. I've never been asked that before. So particularly, I don't, I'll be quite honest with you. That's something I can certainly look into for you. I've never had a patient complain about losing a significant amount of weight. But again, like sometimes some of these effects could be due to the condition progression itself as well, right? Not just the levodopa carbidopa, but that is something I can certainly look into and do a little bit more research on.
Okay, thanks. There's quite a few questions here, so we'll try and cover as many that we can.
Sure. Yeah, absolutely. I'll try my best to answer them.
Someone's asking if there's any other drugs besides levodopa that can address the problem of freezing.
Address the problem of freezing? Sorry. Oh, of breathing or
freezing, like freezing in your feet.
Oh, okay. Like in terms of circulation and things like that. So this patient is particularly having a problem with levodopa-induced circulation issues in feet. Is that what I'm understanding? Is that correct?
I think they're wondering if the levodopa medication will help with the phenomenon of freezing. So the feeling that you're
okay.
Yeah.
Perfect. Sorry, I didn't really catch that. Okay. So honestly, it may. So sometimes these odd phenomenons that occur in Parkinson's patients, like dystonias or issues with changes of like your feet feel numb, that numbness, tingling sensation, that tremor effect. The levodopa carbidopa, really its job is to essentially help with that by increasing that level of dopamine. So that's certainly something that can help. Also, dopamine agonists can help with that, right? Really, any of the therapies we discuss can potentially help with that. If it is a characteristic of the condition itself. So the goal at the end of the day is to manage the condition itself. And if we can find the right medication regimen, then certain phenomena like that numbness feeling can be helped by various classes of these meds. So
okay. There's a couple questions about the effectiveness of the controlled release or the CR version of levodopa. A couple folks have heard that supply sources in Canada have there's a lot here, but they're wondering how effective it is. And someone else said that they had heard that it is not as effective.
So the CR formulation, so in terms of CR formulations, when we look at like the brand name versus the generic name, I often get questions about that. Now, the first thing is the brand name Sinemet, in my understanding, is it's been discontinued. So we do still have the controlled release formulations of levodopa carbidopa available in Canada. Now, in terms of its effectiveness, it's not going to be as effective in some Parkinson's patients as it will be in other Parkinson's patients. Also, it's not often where we start with therapy. I know that CR formulations, in my understanding, are usually added if there is more of like an end of dose wearing off effect of the medication that we need to control. So sometimes, depending on symptom progression and the timing of symptoms, there may be a wearing off effect. And if that's occurring, then a primary care provider or neurologist may add on a CR regimen into an IR regimen, or may change a regimen completely to CR, right? Now, in terms of whether that's going to have effect, it's going to be patient specific. I've had some patients do very well on CR formulations. I've also had some patients do not quite as well. But that's where, especially in Parkinson's, it's very important to get a patient diary chart to ensure that we know what's going on, when it's going on, so we can attribute it to in terms of timing of the medication and make necessary changes if necessary. In terms of whether it's effective or not, I think the answer to that is it is in some patients, and some patients it won't be, right? Because that condition will be different in each individual patient experience.
Someone says that they are having trouble sleeping at night, and they are trying to go without taking an additional levodopa at night. Do you have any suggestions?
Okay. So sleep issues, insomnia, very common condition in Parkinson's. Something that you should definitely talk to your primary care provider about. Sometimes the sleeplessness can be caused due to certain doses of levodopa. Say if it's causing things like dyskinesias or issues. So that's where certain regimens may need to be altered, or CR formulations maybe need to be introduced, or medications may need to be changed. There is medications that can help with sleep. So kind of some of the ones I mentioned earlier, especially in some of the Rem sleep disorders, which can occur in Parkinson's. Melatonin is sometimes helpful. Now, would I go out and buy melatonin without talking to my neurologist or doctor? Absolutely not, because it may not be suitable for every single patient. It's something that you need to, talk to your primary care provider about. And then, other medications are available as well. It's going to be very individualized. So sleep issues are often a characteristic of the condition itself, but it can also be medication induced. So figuring out what the cause is may help in figuring out what the next steps are. Especially if it is a drug induced phenomenon, then a change in medication regimen may be warranted. So make sure that that's something you talk with your primary care provider about.
We'll do a couple more here. So someone is saying that they take their medication at 11:30. They have their lunch right at noon, but then they often feel very tired right after lunch. Do you have any suggestions to resolve this issue?
Okay, tired right after the lunch period. So fatigue, unfortunately, is also a big non-motor symptom of Parkinson's. Now, sometimes that fatigue is due to the condition itself. Sometimes it's due to wearing off effect of the medication, or the medication's not peaking in time to help combat that effect. So, I mean, if like the noontime issue is where that sleep phenomenon is occurring, you'd have to look at certain behaviors, like, are you taking naps during the day? Are you what sort of foods are you eating at that time period? What sort of other things are you doing to help kind of combat it? So it may be kind of specific in terms of figuring out what may be causing that phenomenon for you, because it may, could potentially be medication induced. Maybe the levodopa carbidopa isn't peaking fast enough to help with the fatigue associated with Parkinson's, or it may be a phenomenon associated with something else, right? So really talking to your primary care provider and, figuring out with a patient diary chart, figuring out exactly what you're doing in the day may help us figure out a, conclusive conclusion. Also, energy and fatigue for patients, it's a chronic issue, especially in Parkinson's patients. So getting your lab work done to figure out if there's any electrolyte abnormalities, any iron deficiencies, any issues with your thyroid, or any other medical conditions that haven't been addressed, those all need to be looked at as well. So I don't really think I have an easy answer for that, because we need to look at the body as a whole. We need to look at what is happening with those with the lab work and everything, and the behaviors during the day to help kind of impact that. So great conversation to have with your primary care provider, and they'll be able to figure out a solution there for you.
Okay. And then we got some more clarification on what they were trying to ask about controlled release. So they're wondering if Canada's supply of the controlled release is substandard to what's supplied in the States.
Oh, okay.
That one might need a bit more research.
So I'll be honest with you, like in terms of supply issues and manufacturing, I don't know if they're what the difference is between the Canadian and the US supply of the CR version. I did read a few articles saying that they did discontinue the CR supply of brand name in the States as well. Although I could be wrong because I don't practice in the States. So, but I did read a few articles indicating that may be the case. In terms of whether our supply is not quite as good as the States, I don't know how to answer that question. I would assume it would be a similar supply in terms of where it's manufactured, where we get our supply versus where the States get their supply. I don't really know where that difference would be. But in terms of our drugs, I am proud to say that in Canada, our drug standards are usually quite high. We do have a pretty vigorous control process in approving medications. So I do have confidence in our supply of the Sinemet. And again, I'm sorry I can't speak in terms of the Sinemet CR in terms of your question. But I am confident in our drug supply. I always do think that Canada takes more of a safer approach with medication approval. It can sometimes be a little bit frustrating, I'll be honest with you, because the States does get a ton more drugs approved quicker than Canada does. And I hear that a lot from Parkinson's patients. That was a big concern when we were doing our presentation in Cochrane. Why don't we have this drug, and the States has been having it for 5 years, right? Like, for instance, like apomorphine, Kimobi has been in the States for many years, right? Why are we just getting it now? Why does it take so long? I do think that in Canada, the process is always a little bit slower. We do usually lag a little bit, but it's usually a very safe and rigorous approach in terms of getting medications and manufacturer supplies. So I think you can trust the supply here, but I don't know how to answer that question in terms of, is our supply or manufacturing of that Sinemet CR better or worse? So I apologize. I don't have a clear-cut answer for that.
Okay, thanks. And then we'll do one more, I think the question that's on everyone's mind. Do you know if the COVID vaccine can affect Parkinson's or Parkinson's medications?
That's a good question. Finally, a little in my field. So a lot of what I do is vaccination and immunology and things like that at our pharmacy. So yes, the COVID-19 vaccine, it's very new. People are worried, they're concerned about its safety, especially because it was approved rather quickly in terms of putting an end to this pandemic that we've all been living through. I can assure you that it's very safe in Parkinson's. In fact, I would encourage every Parkinson's patient to obtain the COVID vaccine when they are able to get it, just because the risks and the benefits, like the benefits of getting the COVID vaccine versus the risks of not getting it, the benefits far outweigh them. So especially with COVID-19 itself, we don't know the impact that could have long term in a Parkinson's patient, in an individual in general. We're still learning a lot about this illness. We do know that vaccines are a preliminary way of exposing our bodies to some of this genetic material from that COVID so that we can mount an antibody response more quickly so we don't actually end up contracting the COVID-19 virus itself, which in my opinion, I feel like any long-term consequence of contracting COVID versus any long-term consequence of getting the vaccine, the benefit of the vaccine would far outweigh any risks. And we have seen that there's very few contraindications for the COVID-19 vaccine. The mRNA technology that they're using in these vaccines is very advanced. I think it's going to change the way we vaccinate in the future. I think it'll change vaccines in general, which I'm very excited about. I think we're going to see a lot more illnesses that we can prevent, and hopefully pandemics that we can prevent through vaccination. So, I hate to be that pro-vaccinator kind of guy here, but that is my job. That's pretty much all I do all day. I vaccinate people for a living. And I can't wait to be part of that COVID-19 vaccine and being able to administer it to people so that we can maybe find some sort of normalcy. And rest assured, as a Parkinson's patient, you should not hesitate to get that vaccination.
Good. Okay, thank you. I know that there was a couple more questions that we didn't get to, and it's already 2:30, which flew by pretty quickly. I'm sorry if we didn't get a chance to answer your questions, but if it was a question that you wanted to ask, you can always email it to me and I can pass it along to Shiv and we can see if we can get an answer for you.
Yes, please do. Please do. And again, I wish I could have been more of an expert for all of you guys. I just appreciate you guys having me. If you guys are ever in Cochrane, please feel free to pop by our store. Just work over at 2 Pharmacy there in Cochrane. And I just feel very grateful to be able to answer some questions for you. I hope I did the best I could for you guys.
It was great. Thank you so much for taking your time and sharing your knowledge with us. And thank you to everyone who joined and submitted questions and participated today. Thank you.
Thanks a lot, guys. Have a great day.
You too.